Right. It's 2 o'clock, so we can make a start as we have to finish by 3:30 for the plenary sessions. We have got a lot of things to cover. We'll make sure that we do it in time. So I would be requesting the speakers to limit their talks to 15 minutes. Is that okay? You can all hear me clear? Yeah? Okay. So let me introduce myself. I'm Atif. I'm Dr. Atif Salim, one of the palliative, the only palliative care consultant in Peshawar, Shaukat Khanum, Peshawar. Um, I'm also heading the internal medicine department, and I'm actually the supervisor for the CPSP, the palliative medicine session. Right. Okay. I got actually another role that I'm not going to disclose here. Anyway, let's start. Okay, so the theme for today's session is the challenges towards the end of life, and so the more you will hear about this topic from our speakers. The first talk, let me first introduce the chair. It's an honor to have Dr. Sheikh Moin Al-Haq with us. So he's actually a graduate from AIMC, that's the Allama Iqbal Medical College, and he was trained in UK. He started his career as a consultant in actually Shaukat Khanum Memorial Hospital, Lahore, in 1994 at the inception of the hospital, and was involved in the initial startup of the palliative care services at the SKMT. He is a fellow of Royal College of Edinburgh. He holds CCT and Masters in Palliative Medicine from the UK. He previously served as a consultant palliative medicine at Whittybush Hospital in Wales from 2003 to 2012. And he's currently working as a consultant in palliative medicine at the Hospital of St. John's and St. Elizabeth, also at the London Clinic and 10 Healy Street in London. So I'm going to request Dr. Sheikh Moin Haq for the first talk that will be on challenges towards the end of life. That's going to be in the West. Thank you.
Assalamu alaikum. Can you hear me? Okay. The number of challenges at the end of life. I think we've got 4 interesting talks. I'll start with the first one, which is a problem that we see very commonly in people with advanced cancer, and that's called malignant bowel obstruction. My talk is really going to be focused on just talk to you a bit about the pathophysiology of the bowel obstruction, this evaluation, and I'd like to then leave the rest of the time to focus on the management, the palliative management of malignant bowel obstruction, because a lot of these patients actually cannot be cured surgically. So, sorry, you'll be forgiven to think that colon or bowel cancer is the commonest cause of bowel obstruction, but it's actually ovarian cancer that tops the list. And this is because it's the way the cancer spreads all over the abdomen. As it involves the peritoneum, it tends to stick to different bits of the bowel. So you gradually and progressively develop bowel obstruction, and it's often at multiple levels. And bowel obstruction, when you think of it, you sort of think of a dam in the gut. It's not always a complete blockage, like the gut has become narrow completely, but it can actually be infiltration all across the lining of the bowel. That's where all the nerve plexuses are. So the gut slows down. And if you think of a patient with advanced cancer who's on opioids, he's got involvement of his bowel, He's not really moving around very much, not enough fluids, not enough nutrition. To me, that's what we call the perfect storm that leads to an obstructed picture. So it tends to come gradually, and often the bowel obstruction can be partial to start with. And a partial bowel obstruction essentially means that they're still able to pass flatus at the very least, or there's intermittent constipation. They're not all vomiting at that point, but that can happen. It's can be at single sites, and I think it's really important to recognize the non-malignant causes of bowel obstruction in the cancer patients. The treatment can be completely different. I've seen people who've had abdominal surgery, they're left with scarring, and the scar is actually the cause of the bowel obstruction. So any other cause of bowel obstruction that can occur in somebody without cancer can happen in a patient with cancer. So it's you've got to have a very good overall assessment of patients. And as I said, it could be partial or complete, and I will come to it in the end because your treatment plan revolves around whether it is partial or complete. That's the key question that you got to answer. You know, putting in Ryle's tubes and IV fluids is the standard way of treating, but in 1985, Mary Baines, who's still alive and lectures on bowel obstruction, presented a paper and wrote a paper about 40 patients. And she found that a lot of these patients had multiple levels of obstruction and very few, in fact, there were 2 out of 40 that could actually have surgery. But the rest of them, they were managed medically with medicines to alleviate the symptoms of bowel obstruction. So pain, nausea, and they were still able to eat and drink a little bit. So, palliation means cloaking, doesn't it? It means to cloak, to hide. We don't cure anything. We actually make them feel better. Um, One of my friends, is a surgeon. He said, "What do? You just give morphine, don't you?" And I said, "Well, what I do is when you all give up, I still make them feel better." That's what palliative care is about. Um, so the usual diagnostic assessments. Um, Couple of things to say. Always look for hypercalcemia that worsens bowel obstruction. Look at renal function. It's relevant in terms of the opioid you use. Morphine accumulates in renal failure. So L-fentanyl, fentanyl are the drugs of choice if you need pain relief. I know you are limited in that in this country, but I think you have access to fentanyl. So maybe that would be something that you need to look at. And, as a medical student, I was always taught to think of hypothyroidism. It's not that malignant bowel obstruction is related to that, but this is just part of your complete assessment. Almost all of your patients will have CTs now, won't they? So you would be able to see the cause, the level, partial, complete bowel obstruction. So you understand the anatomy of your symptom. I think that's critical. Um, in terms of management, surgical palliation, if possible, relieves symptoms very effectively. So, you know, forget the volvulus and stuff, but the colectomies or a colostomy or an ileostomy or a tracheostomy. He was vomiting and he had a gastrointestinal bypass and he was okay for 10 months. So your surgical colleagues can actually help you in managing bowel obstruction in certain cases. This is not always possible, but you need to get them involved. Stents, you can put stents in lots of places, esophagus, duodenal, colonic stents. These can be of use in certain cases. Again, I remember seeing a 92-year-old lady with rectal cancer. There was just that, and she was not for any further treatment. We had a stent put in, had radiotherapy, and that was the definitive treatment for her. So her symptoms were resolved. So think of what you can do. Not everyone is imminently dying with it. What I want to talk to you about the palliative aspect of bowel obstruction, as I said, you've got to make the distinction on whether this is partial or complete. A partial bowel obstruction, the whole idea is to soften and squeeze like a toothpaste. Say, and you squeeze with metoclopramide. And the best way to do that, obviously, Docostate has to be given orally. But when you've got problems with the bowel, always go with the syringe driver first. Use it parenterally because absorption is very variable. So if you soften and squeeze, a lot of us will use dexamethasone as well. Nobody knows the real dose of dexamethasone. 6 to 8 milligrams, 5 to 7 days is often what we all do. You can give it subcutaneously, and in some cases, the obstruction gets better. There is frankly no evidence, no clear evidence that this is of benefit, but this is worth a trial. And obviously, managing constipation. Constipation doesn't cause bowel obstruction, but is a very common precipitant. So you can, in a partial bowel obstruction, you can try to move the bowels from above, but enemas and suppositories, these are also very important to relieve constipation. Managing pain, most patients that we eventually see are already on some amount of painkiller. What you want to avoid is hyoscine butyl bromide, buscopan, in partial bowel obstruction. If you use that, it's an anti-secretory, it will paralyze the bowel. So if it's going to unobstruct, it's not going to. So uh, we use syringe drivers for that, and people tolerate that quite well. It's a different story when the bowel is completely obstructed. When you got a complete bowel obstruction, there is not even, they can't even move flatus. Vomiting, sickness are important features, and pain. And you want to manage pain with opioids, and you can use the buscopan at that point. Because some of that pain is colic, but buscopan, hyoscine butyl bromide, is also an anti-secretory. It reduces the amount of secretions in the gut, so there's less to bring up. Similarly, with nausea and vomiting, a lot of people, the typical patient with bowel obstruction says the vomit just comes up. Nausea. It's really important to ask them, when you eat something and have some, does it just come up? Or do you get a lot of nausea in the background? Sometimes they have nausea as well, obviously. But typical symptoms with vomiting is a mechanical thing. It just comes up. Um, and you can manage that with cyclizine, haloperidol, levodopa. You can use pretty much antiemetic that works. Um, because the bowel is completely obstructed, the fluid has nowhere to go. Part of the treatment here now is to reduce secretions. Octreotide and hyoscine are the two that we use, and octreotide can be used up to a milligram. I've used higher doses. Same thing with hyoscine butyl bromide. Um, Nitidine, as an additional measure to reduce secretions, is no longer available. I now use esomeprazole or a PPI. You can give it under the skin as an infusion. I talk a lot about subcutaneous infusions because when you work, certainly in England, when you work in hospices, you can give a lot of these medications under the skin, by the way, and that allows you to manage these people with syringe drivers at home. The important thing to say here, though, is never tell your patients that you're going to, the nausea, sickness will completely go away. It doesn't. The idea is to reduce the frequency and the intensity of the vomiting and manage the pain. If somebody wants that done, then this is about octreotide. Uh, you will have to decompress the bowel. Some patient will turn around and say, Doc Saab, I don't want to vomit. I cannot face it, feculent, horrible vomiting. Some people ask for that. And there you've got to have a tube in. You can use other medications to reduce secretions, but the tube, the Ryle tubes, will drain all the stuff that is accumulating in the gut. You can also use a venting gastrostomy. A venting gastrostomy is like a PEG tube. A radiologist can insert it. If it's technically possible, there's not too much cancer around. It's inserted in the stomach, so all the stuff that goes in the gut can actually come out through that, not through the vomit. So I recently treated somebody who wanted his orange juice. He's so important to him, it's completely obstructed. He was having his orange juice and kept it in, tube was clamped for a little while. Then you open it and it all came out. I was happy to live like that. So the idea, obviously you cannot cure it, but you can make them feel better. Um, Parental nutrition, it was a complete no-no at some point, but I think you can consider people with a longer life expectancy for parental nutrition. Most people that I see having parental nutrition are those who are actually having palliative chemotherapy. I have to say, I've never seen it work. It progresses in virtually all of them, but it's a consideration. Some people, I think there are very few people where we think it is appropriate to consider parental nutrition. Often people have a cancer cachexia picture, which is due to systemic effects caused by the cancer. It's not just the nutrition side of it. So they don't really actually benefit. So, but it's something that is to be considered. And I think in my slides, I've made references to papers that you can all go and have a look at just to get a better idea of what the research in this area looks like. Um, this is just an example of somebody who had bowel obstruction, presented to hospital recurrently with partial bowel obstruction, eventually got completely obstructed. So the partial bowel obstruction, you may have tried dexamethasone, metoclopramide, docosate, try to alleviate constipation whichever way you can, try to get rid of the medication that are likely to anticholinergics. These drugs can slow the bowel. You have to think of those. But then eventually gets completely obstructed. And the objective here was to keep him comfortable, manage his pain, manage his sickness. And people with that can still eat and drink a little while, a little bit, almost till the end. Complete bowel obstruction is a very poor prognostic sign. Hardly anybody survives a few weeks after that. So I think that's um, pretty much, you can pretty much tell patients that, they're approaching the end. A short talk. I think you need to anticipate the problem. It's going to happen when there's abdominal disease. It happens a lot. Every time I hear a CT scan, somebody's constipated, there's peritoneum involved, I'm starting to think the gut is slowing down. It's not a complete dam, but it's starting to slow down. Um, Always ask your surgical colleagues. Ileostomies, colostomies help. They're not always possible, but they can be considered. Um, Medication through syringe drivers, obviously, as I mentioned, always look at constipation, common problem, and try to resolve that. Sometimes that makes things better. Partial obstruction, steroids or metoclopramide, complete, just relieve pain um, and vomiting. Obviously, a poor prognostic marker. Um, where do you treat them? I think we're going to hear about home care that is starting here. A lot of people, there's something called PPC, PPD, preferred place of care, preferred place of death, is something that we measure nationally so that we are able to respect the wishes of patients. Difficult. It requires a lot of resources, including cares. Always think of Ryle's tubes and vending gastrostomy. Sometimes there's so much vomiting that you just have to um, use those. And some of your patients will actually request it. It's not a pleasant thing to have, but if that's his choice, it can be done. It's very difficult to manage them at home because if it gets displaced, they have to come back and you have to look at the placement and stuff. But those are the challenges, and those are things that you see with bowel obstruction. Is a common problem. I don't think there is a week, certainly no month, where I haven't seen a few cases with malignant bowel obstruction. Thank you.
Thank you. We'll take the questions towards the end of the session. Um, Last time I used cyclazine was in England. So I've been in this trust for the last 9 years. I'm not trying to say that I'm old now, still young. Um, Levomethomazine was available for sometimes a couple of years. Then it's not. So we do face a lot of difficulties, especially towards the end of life. So this is what our next talk is going to be about. This will be by Dr. Iram Kafu. She's the consultant palliative medicine and the lead of emergency services at Shaukat Khanum Memorial Cancer Hospital in Lahore. She's a graduate of University of Health Sciences and completed her FCPS, and then she joined palliative medicine. She successfully completed the International Fellowship Training Program in palliative medicine from the UK in 2023. So over to Dr. Ghafoor for the talk on challenges towards the end of life in the East.
Thank you very much for the invite. As Dr. Atif said, I'm Iram Ghafoor, and I'm working as a consultant in palliative care internal medicine at Shaukat Khanum, Lahore currently. Just to disclose that I have no actual or potential conflict of interest in relation to this program or presentation. I have no relevant financial and non-financial relationships to disclose. When we talk about challenges towards end of life care, it's important to really understand what end of life care principles are, so that when we know about the principles, we are more able to understand what the expectations are and then go around that. But having said that, I would say think about it when it's already end of life. Why are we even discussing it? So I'll come to the answers to both. Uh, the principles of palliative care includes the holistic approach, which means covering everything from all aspects, including spiritual, social, emotional, and psychological needs. It also requires family-centered approach, where parents of young children, families, all the caregivers who are all involved, they need their input. And from the medical side, it is also not only doctor led. It requires a multidisciplinary approach, and this requires collaboration between doctors, nurses, ancillary team, and social workers. So, when I say why we are discussing it, this is the answer, because how people die remains in the memory of those who live on. So, it is for us to really understand, and it is for us to learn to make this better. And what happens if the impact is right? When we get this care as a right, this is a feedback from one of the patients, and I'll just read it out. To have to lose someone close is an extremely difficult experience, but we could not have wished for a better death for mom. And she was comfortable at the end and left us dignified, pain free. We were able to spend quality time with her, and we were there when she passed away. And we were all looked after to the absolute highest standards. So I think it's a wonderful feedback telling us what a family would want at the end in terms of, a good closure to, let somebody go. Um, as Dr. Moin has mentioned in his talk, challenges towards end of life, the cases are still, the cases in East and West are the same. My talk will cover about some other aspects of the challenges that we face in the East End, where Pakistan will be taken as an example. We will analyze the unique challenges presented at the end of life in this part of the world, review the palliative care landscape of Pakistan. We will also discuss the cultural and societal barriers to go for this hospice programs in Pakistan. And we will also review the current models of end of life care provision in this country. Apart from that, from the treatment end, I would say we will try to understand what end of life is, explore the end of life period, um, try to consider what symptoms can be experienced, so that we need to master ourselves to deal with those, and identify the important aspects of communication as end of life nears and after the death, what is required to deal with the family, and factors influencing familial readiness to let go. So, in order to understand this, we need to realize that the model of the demographics of palliative care has kind of changed. The lower one is the previous model, where it was like palliative and end of life care will begin once all the hope and the comfort and everything ended. And then there's a transition from curative care to palliative care. So this is now changed into the upper model, which is palliative care, where you can see even from the beginning, the palliative care is introduced more or less side by side to the curative care, more for symptom control and more for getting more confidence in the teams where the patients are looked after, and also to really make it easy. The transition when the curative care is ending and the palliative care starts taking more role, it's easy for the families to understand. It's easy for them to continue care. Um, we don't have really hospices care, so this is the best possible care that we can offer. And then palliative care takes over with the hospice, and then the last phase can be dealt only by palliative team without the curative team involvement. Just to summarize, recognition is important. We can only provide best possible care at the end once we realize that the patient has entered into irreversible phase of end of life care. So recognition is important. Then assessment of the needs. What are the needs? Maybe and their wishes, as Dr. Meen said. Some patients prefer to be at home. Some prefer to be in a hospital setting. So it's important to identify so that we can talk about their advanced care planning, their needs, and then talk about what the family wishes are. As you can see, there's a lot of things which requires emotional support, practical support, and advanced care planning. In case of patient themselves, the quality of life matters. People matters, like somebody wants some special people around them at that time, so we need to make arrangements accordingly. And the last is environment, where they want to be. Eventually that will lead to a more comfortable and more dignified death. So the common elements of good death are: number one, the most important, that people say they want to remain symptom free, which is, I think, the most important aspect: adequate pain and symptom management. Then is avoiding anything that may prolong the suffering. Clear communication about the CN by patient, family, and physicians. Also, adequate preparation for death for patient, feeling of a spiritual and emotional sense of completion. Then affirming patient as a unique and worthy person. So every person matters, everyone matters. Strengthening the relationship between their loved ones and not being alone. That's very important. What are the challenges to this all? Number one, failure of healthcare providers to acknowledge this, because we don't have enough palliative care people around, and it's important to learn and to recognize and to realize that once the irreversible phase has entered, it's important to recognize that death is approaching. So rather than spending our energies on things that are not really going to help, it's important to change the paradigm of treatment. Lack of communication among decision makers, disagreement regarding the goals of care. This also sometimes happens when there is not enough good communication. Then failure to implement a timely advanced care plan. This comes in when we haven't recognized things in the beginning. And lack of training about effective means of controlling pain and symptom, right? I'll talk about the other challenges. General healthcare infrastructure in Pakistan. As you see, public healthcare infrastructure in Pakistan is fragmented and insufficient, I would say. There is absence of health insurance coverage, employer benefits, old age benefits, and 87% of the total expenditure is out of pocket. So that makes things even difficult to, take decisions and then move on. The health expenditure is only about 2.6% of the total GDP and 0.83 physicians per thousand inhabitants. And when I say 0.83 physicians, I mean general physicians. This does not include palliative ones. When I talk about the challenges in terms of demographics and population, we are known to be living in poverty, increasing geriatric population. We have got extended families to also come and take part in decision making and affect the autonomy. Um, there are vulnerabilities without familial support and adaptation to cultural and societal norms. So this is a study that indicates the palliative care needs in Pakistan. Um, these are the conditions where palliative care is required, not only for malignant but also for non-malignant cases. But as you see, more than 800,000 total patients are in need of palliative care. But are we able to give them that support? So the relationship between palliative care providers and the population, this is as per the study which was done in 2021, it estimated that less than 1% of our population has access to palliative care services, which means there's a lot of room to groom, grow, teach people. And while we are doing this, definitely it takes so much time. So there are other ways and means to go around it by doing sessions and teaching sessions of journal physicians and doctors who could provide adequate end of life care by learning about dealing with the symptoms. We cannot bring about as many palliative care doctors right away. So it's important to deal with this challenge from another aspect, like teaching sessions like we are having now. So, medical and institutional challenge in palliative care is insufficient public health, care infrastructure, and fee of service model, lack of health insurance, as mentioned earlier. There's also one thing, poor referral system. Poor referral system comes in because when will you refer somebody? When you recognize. How will you recognize when you learned that this is the space? So this needs regular teaching sessions so that proper referrals can be made in time. The next challenge is availability of medications required for palliation that I'll come in detail, and lack of industry and pharmaceutical support to provide those medicines. Just to say that we have these medicines available, which includes buprenorphine, that too only in the sublingual form, not in the patches form. We have got nalbuphine, tramadol injectable and oral both. Tapentadol, surprisingly, that's readily available everywhere. And adjuvant analgesias. When I say adjuvant, this means NSAIDs, steroids, neuropathic agents, and some other medications. When I talk about strong opioids, morphine is available only at specialized centers, and that too in oral form as well as in infusion form. But we are not allowed by the law of this country to use the injectable form outside the hospital premises. And this has limited us to bring the quality of life improvement at home via these parental models. This study was done in 2017 when transdermal patches of fentanyl were available. They are not available anymore. We do have fentanyl in the injectable form that again is to be used within the hospital setting only. Just to map out, these are the cities of Pakistan where community-based home palliative care service is, working. Where Peshawar and Lahore is because of Shaukat Khanum. We Karachi by Al Khan, and there are few centers and few residential hospices. So this is the map indicating, how much the requirement is and what we can offer. So just to summarize, palliative care brings in or starts earlier. It covers so much: symptom control, management. Eventually, the patient enters into the end of life care, which is generally the last year of life, where condition is non-curative and patients have months and weeks to live, where we focus on the symptom control and other burdens. And from there, once the patient enters into the terminal care phase, that's when our input is most important to provide adequate care. When I was talking about the symptoms, these are the anticipated symptoms that we expect any patient at that end of life care phase may suffer from. When we know these are the symptoms, only then we'll be able to recognize and prepare for these. Provide medications in accordance to management of these specific symptoms so that end of life care can be increased, can be provided even at home. So as I said before, end of life care is everyone's business. So rather than link general population and public, the specialist, this is the gold standard framework of UK. The specialist care comes at the end. So you can talk to palliative care physicians about difficult cases, but I think it's important for the journalist to really learn and to apply that home care, what they can do about primary care, home care, hospital and domiciliary care at end of life care within their areas so that a proper end of life care can be provided. And this is what you can achieve, by having good end of life care where patient can be at home among their loved ones, supported, symptom free, not alone, and where the grief can be reduced to minimum because the family is satisfied because somebody has died dignified. So thank you. If are there any questions?
We'll take the questions towards the end.
I have a
Vidha.
few, if you let me
Sure,
just run through them
sure. Okay,
for the
right.
audience.
Okay.
So I just want you guys to think over so that we can have the answers from the panelists at the end. Being physicians, how often can you give morphine for symptom control at end of life care? Can be 20 minutes, 30 minutes, hourly, or for 4 hours. Same goes for midazolam. How often can you give that for end of life care? What would additional PRN morphine or midazolam requirements are if somebody is already within the hospital and on the syringe driver? What would you do? Would you give extra? And which means sometimes, never. Will you ask somebody, or you will always give extras? Right? These are the questions. Just think about them, and then we'll talk about the answers. And you administer to a patient a PRN or as needed morphine, and 30 minutes later they're still in pain. Now, what will you do? Will you give further dose? Will you phone somebody, medical staff, palliative care, or call somebody else? And when I said the anticipatory bundle, anticipation of all the symptoms, are you aware of anticipatory drugs that you can write? Thank you so much.
Thank you, Dr. Rahul. Right. I thought I was sitting in an exam. Anyway, so coming back here, right. So we were talking about the end of life. So it's not difficult in adults. It's very difficult even in children, the teenage population. And this is what we are going to talk about now. We are going to discuss now. This would be by Dr. Habiba Zahir. Dr. Habiba Zahir is a clinical psychologist and consultant at the Department of Oncology in Aga Khan University Hospital in Karachi, where she leads the psycho-oncology services with palliative medicine section. Her area of expertise are caring for the pediatric population, the pediatric palliative care population and their parents. So over to Dr. Habiba Zahir.
Assalamu alaikum and a very good afternoon to everyone. Um, as clinicians, we learn how to diagnose, how to cure, how to treat, but only a few of us are actually taught how to care when cure is no longer possible. So, today I'm going to talk about one of the hardest yet the holiest aspect of medicine, which is pediatric end of life care. Because behind every face, every diagnosis, there is a child, there is a family, a world that changes forever. And my goal today is to help us understand that world, not through statistics, but through an eye of compassion. I have nothing to disclose. So, before we begin, let's take a quick look at what we'll cover today. We're going to talk about the landscapes, understanding why pediatric end of life care is important. Then we'll explore the children's experience, the the family's journey, and also the cultural context here within Pakistan. And finally, we will talk about the pathways forward, how we can bring in compassion and meaning to the end of life care. So, I'd like to begin with this beautiful quote by an American author, Madeleine Langer, who is well known for her work and reflection on faith human experience of suffering. She reminds us that a child's end of life is not only a medical event, it's an emotional earthquake that shakes the entire family system. So let's take a moment to understand the landscape. Every year, over 21 million children around the globe needs palliative care. That's an enormous number. And behind every number, there is a face, there is a child that once went to school, laughed with friends, and now is stuck within the hospital territory between all these hospital machines. And almost 90% of these children live in low and middle income countries like Pakistan, yet only 10% of them receive the care they really need. So in Pakistan, pediatric palliative care is still in its infancy stage. We have some tremendous, amazing clinicians who are doing heroic work, but we still have limited um, designated services, very little psychosocial support, and strong cultural barriers when it comes to talking about death or dying. So let's step into a child's world. Imagine being a 7-year old and surrounded by doctors, nurses, hospital machines, and so much fear. Children often fear the unknown more than the illness itself. They can sense everything, they sense the pain, they can see their mother's eyes turning red after crying. They can see their fathers going silent. They can sense the whispers in the room. And they have so much fear that they start asking questions. Am I being the burden? Am I being the one responsible for making my parents sad? And this is devastating because the child who's already facing death is also experiencing fear that he's being or she's being the burden on the parents and the family. So, when we talk about pediatric palliative care, we actually talk about helping that child to understand and make sense of those fears and their journey as well. Um, Illness takes a lot of things away from a child. It just doesn't take away health, but so many other things. For example, loss of control. Imagine being told what to eat, when to sleep, when to eat every time, because all of these decisions are being made only by parents. They cannot decide anything on their own. And this drives them towards being irritable, frustrated, because they're losing their control and autonomy. They become rigid. Body image, disturbed body image, especially in young adolescents where so much of their self image depends on their physical appearance. So, scars, medical tubes, IV lines, and loss of weight and loss of hair. This all creates so much emotional tension and distress among the among the children. And then social isolation. They see children and their siblings, their friends, their cousins playing around, going to school, doing everything that they once used to go do, and now they're stuck in the hospital. So all of these things, they start asking questions that no textbook could prepare us for. Questions like, why me? Am I going to live like this for the rest of my life? When this misery is going to end? Is it going to be more painful? So these are not just medical questions, these are emotional cries, basically. These are existential cries for meaning. And as a clinician, it's our role not to answer these questions with information, but with so much compassion and with empathy. Children understand death differently depending upon their ages. For example, infants do not understand the idea of permanence. Yet they do understand absence. They would cry differently when their mother doesn't come away, but they don't understand the idea of permanence. Preschoolers believe that death is reversible, meaning that they or anyone who die is going to wake up again. It's like a longer duration of sleep only. And then age 6 to age 7 is the age where children start understanding that death is not reversible, it's final. But still, at the back of their mind, there is a concept that it could only happen to other people, it can never happen to them. Finally, adolescence is the time where they start realizing that death is inevitable, it's universal, it could happen to anyone and to them as well. And this causes them pain, anxiety, fear, sadness, and sometimes grief, as anticipatory grief as well. So, when a child is sick, the entire family becomes patient. Parents start mourning long before an actual loss. They start grieving all those birthdays that are never going to happen, the college admissions, the graduation ceremonies that are never going to take place. So they start grieving all of these things. And then every medical decision feels like a burden, whether to, just give another shot of chemotherapy or stop it. Every medical decision feels like a moral test of their love. They have unbearable guilt, so much guilt. They start asking questions: is it me? Am I the one responsible for my child's suffering? I still remember there was this one patient of mine who lost her daughter because of AML. And she used to ask questions. Like, she used to blame herself all the time that maybe be it cousin marriages, this was the reason my child suffered. So they have unbearable, immense guilt and they blame themselves for everything. And then there is helplessness, which is extremely disturbing because as a parent, you're supposed to protect your child, but they're helpless in the face of this reality and situation. So we need to understand that these are not just caregivers, these are humans carrying the immense, unbearable emotional burden one could ever imagine. So, the child sickness doesn't test parents as individual; it tests their relationship. Some grows closer, others may drift apart. Uh, Maybe one wants to cry, the other one wants to go silent. One wants to talk about it, the other one wants to shut their feelings and emotions. So, this difference in coping mechanism could create distance. Research shows that 16% of marriages end after the loss of their child. And this is not because of lack or loss of love, but because pain leaves no room for communication. Now, forgotten ones, the siblings, the silent mourners. They're often standing in the background of every hospital photo. They don't understand what's happening, but they do sense the tension, the whispers in the room, and they sometimes feel guilty. Sometimes they feel uh, angry because they are not the one who's getting all the attention. So it's a mixed feeling and emotion. So it's important for us. I still remember there was a patient of mine. She said that when my brother got sick, I became invisible for my family and I stopped putting my needs up, in front of my parents because I don't want to overburdenize them because they were already going through a lot. These words stayed with me for a good time and this haunted me because it tells that how grief spreads through the entire family system. In Pakistan, family support um, is a source of both comfort and occasional conflicts as well. Decisions are often made not just by parents, but by the entire family, grandparents, uncle, aunts. And this could actually benefit the family. It provides moral support, but sometimes the same support could bring tension as well because there are so many differences, difference in opinions. There's so much pressure. There is no privacy, pressure to stay positive. So families sometimes just appear and pretend to be strong because that's what their family demands them to be. So we need this, understanding the cultural context and cultural dynamics allows us to see where the families are rather than where we expect them to be. Faith act as a important component when it comes to families who are grieving and it's basically work as a coping mechanism for them. For many of us, qadr, divine destiny, is a source of meaning. To Allah we belong and to him we shall return. This actually serve as a mantra of peace for them. They pray, they recite Quran, and we should respect that. But sometimes the same faith delays important communication and conversation. For example, comfort care. Families may continue providing aggressive treatment because they believe that stopping them would mean they're giving up in Allah, they're giving up on faith. So, as a clinician, it's our role and responsibility to make them understand that acceptance is not defeat, it's basically devotion. The silence around that. In our culture, we don't often talk about that, especially to children. Parents think that if we talk about that to the kids, they're going to lose hope. Well, in reality, they know. They, like we've talked about earlier, they sense every pain. They sense all the whisper. They can see the eyes, with which people are looking at them. But when we're not talking about it, we're basically doing what? We're isolating them in fears. That creates confusion, and they just go into their own cocoon because they don't feel like there is anyone to talk about their fear to. And then they get more confused and more anxious about what's happening. So if we talk about what's happening in age appropriate manner, it would give them reassurance and comfort, and it would build the trust, the level of trust. Let's face the system we work in. So we have very limited pediatric palliative units in our country. Opioid access is restricted. And result, we see children dying because of pain that could have been relieved. Our training programs are still pretty much more focused on curing rather than comforting. And then there is almost none psychosocial support and bereavement services provided for the families. But we need to understand that loss doesn't end at death, it basically begins there. So, bereavement services, counseling support systems for the family members would help them grieve and process their grief. What can we do at this point moving forward? There are multiple steps that we can take. For example, there are many therapeutic strategies, art therapy, play therapy, that would allow the child to explore and express his or her emotions in a non threatening manner. Things that they cannot talk about, they can express them through art and through play therapy techniques. Providing family support, connecting families so that they can each family feel heard, that they would feel that I'm not alone, somebody else is also going through the same process. Then legacy building, meaning making activities, letters to provide something tangible to the parents to hold on to. And then providing anticipatory guidance, what to expect, how grief is going to be there with them, how to process grief, and all of these things. So, before I close, I would like all of you to go away with this one message, that pediatric palliative care and psychosocial support basically is not just something secondary. It's the soul of palliative medicine. Because at the end of the day, it's not the medicine or the machines the children and families are going to remember. They're going to remember the faces that stayed, the hands that comforted them, and those people who actually looked into their soul and supported them. Thank you so much.
Right. So it's actually about adding life to days, not days to life. Uh, so now we'll move on to the home service, a bit about the home service, and we will be touching the nursing perspective, for which I would be inviting our one of the palliative care nurses, Miss Saira Saeed. So we actually started the home services for our cancer patients a couple of years ago. We are covering like 20-kilometer radius in Lahore and in Peshawar. So patients with complex palliative care needs are identified through our helpline, clinics, and inpatient and other are visited. So Ms. Saira is going to talk about the nursing perspective of the visit.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm honored to have to speak about. My all consultants and fellow have spoken about palliative medicine and everything. But when it comes on palliative, it is extended from the nursing perspective, as the nurses are the one who switch the hope, cure from hope to comfort. So we started the home-based palliative care nursing. In home palliative nursing, we will talk about Dame Cicely. She's the one who is pioneer of palliative. She's the nurse, she's the social worker, and she is the doctor. And she said, you matter because you are you. And you matter to the end of your life. We will do all we can, not only to die peacefully, but to live until you die. If you recognize this statement, how beautifully she said that we are going to talk about live until death. We are not going to let the people die with suffering. So home-based palliative care matters is the introduction. Home as a sanctuary. Actually, we know about the home is an identity, it's a safety, as security, and of course, the emotional well-being of family and the patient. So everybody, even myself, want to live around people which I loved, and I want to stay in the home to my identity. Patient preferences. Like I said, I myself will want to stay in the home while I'm sick, so the patients also prefer, with the life-limiting illness, prefer to receive care and die at home. Yet many still pass in the hospital due to some are cultural beliefs and dynamics and not advanced care planning in the end of life care. Proven outcomes, home-based care improves quality of life, reduce hospitalization, dignity, address the priorities are aging populations. Actually, proven outcomes we have received with our home-based palliative care nurses when we started, but in overall countries, we have seen the outcome. People who are living in the home premises, they are dying with dignified death. Cost effective, no burden on family. Like no problems when the patients we ask them to bring to the hospital is a burden. To bring with the ambulance, to the accompany the person, to leave all things and stay with the patient. So it is cost effective home-based palliative service. What nurses does? This is very interesting, and I think so. It's passion about me, palliative nursing. It's extended beyond when we say it's not only physical symptom control, is psychological sport, is emotional sport, is social sport. It's the nurse who talk to the family and the patient and bring out what are their concerns, what actually they are going through. This is nurses assessment. So holistically, we see every aspect of the patient and family. Before there, we were saying centered, patient centered, but in palliative, it's not patient centered, it's family as well come in it. Care coordinations. Of course, the nurse is the pillar between the doctor and patient and family and multidiscipline. And the palliative nurse will assess what my patient need and what my family need. So that's we coordinate between doctor, physician, psychologist. Even if we know that the chaplain in like Maulvi or like in Quran, we are preaching Islam, so we ask them to come in and visit. And even we are the one who are asking the family, if you can read it or recite, you can do it. It is good. Trust, educate. We build up relations. How we built up when we talk, we listen to them, we talk about their concerns, and we acknowledge their problem. Not only physically, we are believing what they are saying, they are truth. And we are trying to accommodate them as their needs individually. Caregiver support. Of course, we elevate the family stress. When we come in, we try to educate them, we try to help them, and we are saying, we are here for you. It's like caregiver support. Provide guidance in complex cases, reducing caregiver burden, like bedridden patients, challenging patients, like pain control patients. So we are care support, caregiver support. This is real world impact case of Miss A. This is the patient who was astrocytoma cases, where the patient bedridden, NGT dependent, pressure ulcer, oral thrush, and on and off headaches. It was difficult for the family to bring the patient to the hospital. And me and my doctor used to visit that patient, even and now, to make them, to alleviate their symptoms. So NG tube being changed. When I visited her, we know what we are going to do it. The patient was having vomiting, they cannot tolerate the feed, so we switch on the NGT and we discuss with the consultant, and then we have changed the NGT in their home premises. I seen the pressure ulcers, and I did the dressing. I did education to the family. I make comfortable to the family and the patient to do this, and then NGT education about aspiration. I give sit with them and they talk with detail what she can do, what they can do, and what we can see about the aspiration and what is aspiration. Oral thrush has been treated because she was having the thrush, and we advise as per doctor advice, and then I come with the nursing assessment that how we can clean her mouth while she's bedridden and open less opening of the mouth. Doctor prescribed medication after discussing, family education provided. Of course, it's a big role of nursing when they come sit with the patient and family and educate about what they can do, because we are trying to make life better, to comfort them. And what knowledge we have, we cannot keep with us. We have to deliver to the family so they can be our partner in caring of the patient. So what come happen? Improve symptom control. Of course, after once we did it, we educate the symptom being controlled, cost effective and convenient as saving patient travel, admission, procedural expenses, reduce patient and family anxiety for prevention of care. Of course, they when they didn't bring it and we are there, we delivered our care to them. They were cost effective. Enhance family caregiver confidence and understanding. Strategies. That what I'm doing. Nursing education. We have to educate our nurses on palliative basis. What actually we are doing. Invest on ongoing palliative care training, mentorship program, and serious illness communication workshop. Build teams. Create integrated multidisciplinary team, including physicians, social worker, counselor, and champions. Enhance communication. Strengthen coordination pathway between hospital, primary care, clinics, and home care service. Enhance communication. We nurses should improve our communication to talk about patient conditions uh, to the doctor, to the consultant, and even to the family about their concerns. We actually don't talk. We don't tell their assessment. What will happen if we wrong? Nothing will happen. But we have our own assessment which we should tell or we should inform or we should encourage to others to talk about. Community awareness. Promote public education and passionate sport network through advocacy and engagement. As we are doing, we are educating everybody. We are telling to the community to promote this on home-based palliative, that we can look after their patient in their home premises rather than bringing to the hospital. Because our myth somewhere that hospital are best place to look after. So when we are telling no, we teach you, we are here for you, you stay there. This is about community awareness. Our commitment. Compassion continues care. Listen and assess. Understand each patient's unique situations and needs. As I said in my previous case, and then I'm saying again, individualized needs as per patient's needs. Support every setting, provide expert care and across phone, clinic, hospital, and home. I'm proud to say that we had 24/7 service over the phone where doctors the only who is receiving the calls and acknowledging patient concerns and telling and advising after consultant talk. Build trust daily, demonstrate our presence and reliability through 24/7 availability and personalized attention. We've seen patients in hospital, clinics, and walking way, and in the home premises, educating all family and patient about the palliative care, what we are doing, because we are switching the role from care to comfort. And this is our primary responsibility. What is take home message? Prioritize home care, recognize home based palliative care as essential to modern healthcare delivery. Invest in infrastructures, support nurses' education, resources, and multidisciplinary collaboration models. Empower families. Like I said, treat family as essential partner in providing compassionate end of life care. Because we are educating, we are bringing them as a team member. Advocate for change. We nurses are the advocator as well. Support policies enable patients to live and die with dignity and autonomy at home. How you want to die, or how I want to die. Live in this place or staying in the hospital. All person has, every person who has opened the eyes has to close. So we need to discuss about death. We need to talk about the death, how I want to die and where I want to die. In comfortable or in the ICU bed, around the family or in the nurses around. So thank you very much for listening me and giving that opportunity.
Thank you. So now we'll move on to the panel discussion. So And for this, we would be having a case, and I'm going to request Dr. Ikra. She is our fourth palliative fellow in the Shaukat Khanum Memorial Trust. So we have one in Peshawar and two in Lahore. And we had one who graduated last year, 2 years ago. Yeah. So, and so this is actually our CPSP approved program. We are running successfully. In the panel discussion, I'm going to have Dr. Moinul Haq, and I'm going to invite Dr. Iram Ghafoor if she can come here. And I would be inviting Dr. Harun Hafiz. So there's actually a lot that I have to say about Dr. Harun Hafiz regarding his contributions, but I don't have time. He's actually the director of the QPSD, he's the consultant palliative medicine, and I'm sitting here because of him. Dr. Iram is here because of him. So that's the summary. Okay, so we'll start with the panel discussion. Oh, I forgot. Yes, agree.
Assalamu alaikum. I am Dr. Ikra, fellow palliative medicine working at Shaukat Khanum Hospital. So today we have a panel discussion about a challenging case that we managed at Shaukat Khanum Hospital. So this is the case presentation of a lady who was 37-year-old female, a diagnosed case of low-grade astrocytoma, and was referred to our hospital for further management. So she was treated with chemotherapy, radiotherapy. Later on, because of progressive disease, she developed hydrocephalus, and multiple shunt placements was done in 2018 and 19. Later, patient had multiple symptoms. One of the symptoms was hearing loss, which was because of the cholesteatoma. So we took ENT specialists on board. They advised surgery, which was denied by the family because of the financial constraints. So later, patient developed gross hydrocephalus because of the progressive disease, and she underwent for multiple times VP shunting, and recent shunt was placed in 2024 October. So, and clinically, there was a gradual decline in the functional status. According to family, there was increased lethargy, recurrent ear discharge, and she was hard of hearing and requiring assistance for her mobility. So, referral to palliative care medicine was done by the primary oncologist because no more intervention was possible at that point. As a family physician, we managed patient symptomatically, and later patient developed seizure-like activity at home. So we did workup. No acute event was diagnosed at that point, and we discussed the prognosis and findings with the family, and we agreed for no more further investigation. And because patient was too unwell at that point, her with anti-epileptics. During this period, we had multiple home visits. We managed patient at home and with the telemedicine clinic. And during this period, in April 2025, she was admitted in the hospital. During home visit, we diagnosed her then that she was not doing well, and the aspiration pneumonia was the diagnosis at that point. She was brought to the hospital and was admitted there. So swallowing assessment was done, which was her swallowing assessment was showed that its swallowing was poor. So we advised NG tube or PEG tube, but this was denied by the patient and her family. Again, unfortunately, there was progressive disease, so patient again presented to the ER with low GCS, and at that time we managed her on the lines of increased intracranial pressure. At the end, in the last, in the middle of the August, she again admitted to the hospital with low GCS, and at this time, the diagnosis was aspiration pneumonia. So long discussion was held between the palliative care team and the family, and consensus was reached that we will not do aggressive testing, and no more further antibiotics and invasive lines would be done. And her IV access was very difficult, so family refused for further IV lines. So we offered the other option that we had at that time. And SKM ELC pathway was started at that point. So I forgot to tell you that we had multiple discussions before that about the end of life care. And PRN medicines of ELC we gave her for her pain, agitation, and dyspnea. So patient was managed on the line of end of life care pathway, and she was comfortable and was passed away peacefully after 2 days, surrounded by the family. Here is my question with my respected panelists that what were the challenges that they encountered while managing this type of patient? So I will,
What's the challenges?
yes.
I think when you see sorry. When you first referred, can you hear me? When you first referred people for palliative care, I think the first thing, we read about holistic assessments. It's not just about, as a doctor, I was an acute physician and then went to palliative care. I had to retrain to think that what am I doing? What is the objective of this? What does the patient want? So, holistic assessment is your medical assessment, but also a lot to do with nutrition, psychosocial issues, patient preferences, advanced care plans. We talk about them. I think challenges vary. A lot of people that I see, obviously, hope is a interesting thing. Some people have accepted that they're going to the end of life, but a lot of people still have hope and they want something done. It's about good communication with the family and to understand it's your medical judgment and their preferences and wishes that have to come together in a meaningful way to address that challenge. That's one aspect of it, but I think your challenge at home would have been how to do a syringe driver and medications, probably. So, a lot of people who want to die at home, we have the ability to do that in a lot of cases in England, where so there are practical challenges, in other words. Um, did you face any particular challenges here from the family or the patient themselves?
Yeah.
I think just to add, what Moin you're saying is completely fine. The issue in Pakistan is twofold. One is the pattern of referral. The referral is pretty late in the disease trajectory. The second is the mode of referral. Often, when the referral is done, patients are not very well aware that they are now going for palliative. And one of the challenges as a palliative care physician in Pakistan is that there is this physician that they don't know, and there is this physician who has been treating their disease for years and years, and now that physician tells them that, oh, we're going to another specialty and they are going to look after you. And often the patient's perspective or take home on that is that maybe I need some sort of therapy or some new sort of treatment, and that's why I've been referred. So the first challenge for at least 70% of patients referred to us is actually the challenge of trying to explain what the scope of palliative care is to them and getting them on board with that. And even if you look at this case, I mean, I feel that the discussion or the time where we decided no further treatment should have been weeks earlier, if not months earlier. And one of the major reasons around that is the delayed acceptance of families and their coming around to the fact that this is where things are heading now. Coming to the point of challenges at home, um, when we trained in the UK, it's a completely different ball game. The GPs take the lead. You only go in, the Macmillan nurses are there. You've got all sorts of medications, syringe drivers, those ones which the self ones where they last only 24 hours. So over here, you're very limited. You can't give morphine at home. There have been cases where at least I have had managed patients, where I've managed patients at home by giving them or teaching the family how to give subcut midazolam every 3 to 4 hours. But that in itself is very dangerous in the sense that you really need to be very sure, and the family needs to have a certain literacy level to be able to understand when to give it, how to give it, and all those things. So, one of the biggest challenges, and that is why, unfortunately, this patient was an ideal patient who should have actually been kept comfortable at home. But eventually, despite multiple interventions at home, despite going in nearly every other week, every week, twice a week, they eventually, for the last few days, had to be brought in home because symptom management was just not possible at home because of the lack of interventions and the lack of follow up. Personally, I feel, I mean, and I've got two of my colleagues here between Peshawar and in Lahore sitting here, and I feel that the way forward now is to develop the concept of virtual wards in palliative care services in
Yeah.
Pakistan, and maybe bring around the legislation to the fact that we should be able to give medications needed at end of life more liberally at home so that we can manage patients at home better and not end up like in this case that when the real time came, unfortunately nothing could be done and the patient had to be brought in.
Yeah.
Thank you so much, sir. So, in this case, clinical challenges were hard of hearing and decreased mobility, and ethical and prognostic uncertainty were the challenges. So, as we discussed, so one of the challenge that I was thinking was major that the family refused for the NG tubing. They denied for the because they think that it would be painful, but the patient had multiple admissions because of the aspiration, but we had no other options.
Yeah, actually, I would add here that I think the family was more sensible than us because I don't think that in this case we should have pushed for an NG. Because at the end of the day, I think there's a lot of focus on feeding, and food is a big part of our culture in this country or this part of the world. And therefore, often the biggest fear that families face at this time is कि ये भूखे रहेंगे, will he be hungry, will he be in pain because they are hungry, or will she be in pain? And that's made us very tuned to trying to put in alternate methods of feeding. In my personal opinion, if you have a good discussion with such a case, you give them thickened fluids to take at home, you tell them you're going to have repeated aspirations, and maybe even discuss with them that you're not going to treat those, is probably the best way forward. I don't know what you guys want to add anything.
So, um, I believe that, in palliative care, the beauty of palliative care is it is around the patient and the wishes the patient have. So, if I want to be a patient, I would want things to be done the way I want them to. I know there are certain things that cannot be cured, like she refused for surgery initially, knowing everything is going to change, her life is going to change. And at the end of life, when she's really approaching the end of life, and when we try to tell her that you need NG, you need tubings, you need things, that's one perspective of it, by preventing her from aspirations, which is also not 100% correct. People with NG do aspirate as well. So talk to the patient, talk about their wishes, and if they don't want to be intubated in terms of anything, in terms of any NG or any other gastrostomy tubes and so on, then go around that, teach families that, feed only when she's conscious enough to take. Tell them the aspiration precautions that they can take at home. If she misses a meal, that's so much better than if she takes it and aspirates. So that's fine to miss a meal if she's not in that conscious state, and then wait until she gets up and then start with the lowest one. And that's where our nursing team really helps, because they go through every fine bit and piece of that and teach family to how to prevent aspiration by the use of sloppy diets, by the use of with the help of speech therapist. So I think yes, this was a challenge. This was more for a challenge, I would say. After doing my FCPS medicine and jumping into palliative care, I had to really unlearn a few things. That it's not about doing and doing and doing until it's the end. It's also about learning when to stop and choosing when not to do, which is going to be better. So that's my take on this.
So one of the challenge was also a psychological support, because brother was only the person who was taking care at home. So we managed that challenge with our psychology team. So and it made a big difference. So logistic issues. So we offered a telemedicine clinic and Also, we have home visits. So we have nurse and a doctor who go to the home and they manage patient at home. And if they feel, they ask the patient to bring to the ER if there is any red flags.
I think with the home visit, it's very important to remind ourselves that we are very limited. I mean, we feel very happy कि हमने home visits, we've started home visits, but it's only a 20-kilometer radius from the hospital, whereas you're taking patients from all over the country. And very frankly, I think our home visit does not even cater to 10% or 5% of patients who actually need the home care. Because most of them are outside our jurisdiction, and it is obviously not safe either. We can't have the medical team traveling 3 hours or 4 hours. It's not cost effective. It's not safe for the team, and there's a lot of other challenges. When we started this home visit, one of the biggest challenges we had was the security concerns around somebody going in with all these medications, and and I'm not being sexist, but obviously most of our team members are female, which brings a different set of challenge with them going into the home. Therefore, that is something that we had to be in mind, and we've got a rule where before they go into the home, they make a phone call to a designated number and say we are going in. And if they don't call within 30 minutes to say we are out, then that person is supposed to alert security and everything and whatnot. And the driver who takes them to anybody's house is supposed to stay out, and he's also made aware that if they don't come out in 30 minutes, he has to do whatever he has to do. So that's a very big challenge, but at the same time, I feel very frustrated that we have this 20, we can make it a 30-kilometer radius, but when it comes to, and I think in every hospital operations meeting, everybody starts looking at me as if I'm a criminal, that there's only 3 home visits, what's going on? And what can I say? Shall I ask everybody to move into a 20-kilometer radius? Then they might as well move into the hospital. So um, that is a challenge that I don't know what the solution is. But to my mind, I think like we have collection centers all over the country, at least my dream is that one day we will have a doctor in all those collection centers and a nurse in all those 200 collection centers who can do basic palliation and advise at home. And that is when I'll say, okay, we have got a home care service. I think we've just got a pilot project.
Yeah. So, Arun, just very interesting. I just want to say two things. The virtual ward is now being piloted across England. Luton is about to launch it. So, 100%, you have to have a virtual ward and run it that way. If one thing COVID has taught us is that we don't have to do everything face to face. There is a lot of opportunity in virtual. It is a way forward. And the second thing, I remember these conversations in the board at Khanum ages ago. कि अभी कितने मरीज देखेंगे 3,000 4,000 10,000 there are hundreds of thousands of people with cancer. So how do you make an impact across the country? And that has to be education and training. You can train and educate everybody across Pakistan over a period of time. We'll never be able to manage all of it, but you're absolutely right. This pilot project can inform the way you sort of scale it across the country. It has to be a very big focus of Shaukat as a premier cancer institute, not just in Pakistan, in Asia. I mean, the standard of care, frankly, is second to none. Um, and one last thing about late referrals, you are not alone. The problem with palliative, I feel, in the West has been it has evolved with end of life. So palliative care equals end of life. We never talk about the quality of living while we are getting to the end of life. And that has been changing a little bit more. There's a model called enhanced supportive care, which was launched by UCLH, where palliative care sees patients with oncology while they're getting chemotherapy. So we see them in that clinic, we manage one thing and they're managing the chemotherapy. So you can start with conversations, forward planning, other things. And then also the doctor, is quite nice. I'm not introduced as the angel of death. I'm actually introduced as somebody who's actually going to make them live better because we're all dying, as you say, right? So I mean, it's quite nice. It's actually, in some ways, to be honest with you, when I was at Shaw Khanum, I felt I was far more proactive than when I went to England, where nobody wanted to talk to me. All the consultants wanted to talk to me. Okay, Dr. Huck, these are 25 patients with lung cancer. This guy is 92. We don't want to have anything to do with him. he's yours. So he's going to die in the last week. That's not palliative care. That's not the future of palliative care.
He's
Thank
just
you
got
so much
one
for.
comment on the angel of death thing that I was once walking in the waiting area of our hospital and two patients were talking. They didn't know who I was. And one was saying to the other, आपको भी डॉक्टर हारून की क्लिनिक नहीं भेजा इसका मतलब है कि अभी चांस है आपका. And I just smiled and I walked off because they were just warning them कि if they get referred to Dr. Harun, that means that's it for you.
Exactly. It's very true. It's very, very true. I've had patients say to me in a hospital, "Where are you from?" "I'm from the hospice." "Oh, I'm not there yet." "Oh my God, what do you think I do?" I mean, that has to change. I think I would be specialist palliative care. The opportunity we have here is to evolve with cancer alongside, not at the end of it. We can actually be way ahead of the curve if we do that.
Thank you so much for wonderful discussion. So, in the last, I would like to say that palliative care is not about giving up, but about offering a better quality of life when care is no longer possible. Thank you so much. Thank you.
Thank you.
Uh, so do we have any questions? Yeah, okay.
Is there a mic?
No.
Yeah.
there we-
Yeah.
So, Assalamu alaikum. Those who don't know me, I'm Rehan Elahi, the Chief Nursing Officer at Shaukat Khanum. And I am the oncology specialist nurse, but now more of administrator. But I really appreciate palliative care since I started working in oncology, studying oncology in UK, all that. In our times when I was a young nurse working in medical ward or surgical ward, seeing patient dying with the pain and all those miseries. Now that have been reduced by the concept of palliative care. मेरा हमेशा ये सवाल रहता है, we have talked about nutrition and we have talked about energy and aspiration. It must be very challenging for the team working here in Pakistan also, how to teach family to withhold nutrition or to withdraw nutrition. Or sometime, like when I was working in Saudi, we always found them talking, okay, if we can't feed our patient, please give him IV fluids. And the doctor used to tell them, look, this is the time to dry up. This is the time to make their death rattles better. We cannot give, but it has been always hard. So how challenging was it? Is it still a challenge, or they understand?
As I just said, in this part of the country, everything revolves around food. Somebody dies, let's have food. Somebody lives, let's have food. Exam में pass हो गए हैं, let's have food. Somebody fails, let's have food. Got a promotion, let's have food. So at that time, in such a culture, when you go in and you say that they can't have food, it's always challenging. But there are ways around it. And I once had a patient who, was very focused like me on eating and was very upset about the fact that he can't taste food anymore and he can't swallow. And I told them that why don't you just take a mouthful, chew it, and spit it out? And at least you'll have a taste of the food and something will get absorbed from your mouth. We all know the digestion work starts from the mouth. And he was so happy because he used to just chew food so he could get the taste of it. Till as long as he didn't really become unconscious and just spit it out because he couldn't swallow because of his parotid cancer. There was no room for swallowing. So he used to chew food, keep it in his mouth, and just spit it out. And so these are things that you just have to adapt because of where you're practicing. But wherever you're practicing, I mean, I learned in the UK because over there, this withholding nutrition is much earlier even today than in our setup because we are very focused on nutrition and hydration, and it takes a very it's one of the most challenging discussions to have, and especially if it's a child, then it's a near impossible conversation to have with parents that your child cannot eat anymore.
Any other question? Okay. Right. So this brings us to the end of the session. I'm very thankful to you all for joining us today. Inshallah, we'll see you all next year as well. Thank you. Thank you very much.